I've been asked to talk about tests and criteria for return to sport after ACL surgery. I can say already that we're using the same tests and the same criteria for those who are not going through surgery, although this will focus more on the surgical part. I've been asked to put up this. How will this talk affect your practice with return to sport after ACL reconstructions? I hope that you will become more structured in scheduling your return to play testing. I also think that you will be more skeptical towards the leg symmetry index of 85 or 90% as a return to play variable. And I also think that you will think twice before advising return to play before 9 months after ACL reconstruction. I'm not talking about rehabilitation, but I wanted to put your focus on this model from the British Journal of Sports Medicine past year from Sam Blanchard and Phil Glasgow, because to me this shows the rehabilitation process after an ACL reconstruction or ACL injury. We start with some exercises, then we add something more, and then we want to change focus and do something else, and then we add things up together. And I would say that a modern good sports physiotherapist is capable of having several of these at the same time for each of our patients. So you have one progression line for hopping, we have another one for running, and we have one for strength, we have one for range of motion, and then the clinical reasoning part of it is to be able to decide which of these should we focus on in the different phases of rehab. I'm talking about testing and functional testing. Claire and the others have already said that we have to look at more than the physical performance tests when we're returning people to play, but my focus today will be mostly on the physical performance tests. Although before I heard Claire this morning, I also put in this slide that we know that there are psychological factors important when we are returning people to play, or if we're going to return them to play. And I've taken sort of the different approach, not those who do not return, but those who do return. They are psychologically ready, they have a low fear of new injury, they trust their knee, and they have good knee function. This, I think we can, as physiotherapists, to see the patients quite a lot through their rehab. We have different ways of helping them achieving these goals. And one of my favorite things to say is this. After a good test, maybe 6, 7, or 8 months after the surgery, the patient has done a good test, and I can tell him, now you're not a patient anymore, you have to become an athlete again. So they can walk out thinking that my knee is fine, I have to train harder, and I'll come back as an athlete. And that's a good thing for them to hear. Your knee is good, now you just have to become an athlete again. And you've done that before, so you have a good chance. And also for the psychological factors, I think being together with others, training in groups, is important. Because ACL rehab after surgery is very boring. It's 9, 10, 11, 12 months, and we tend to put the patients on their own. So this is just an example from the Norwegian Olympic Center where we have this, what we call the acclimatization group, which is the ACL group, where we do different kinds of exercises, trying to have fun at the same time as we're training the knees. So these are this is 1 handball player, 2 alpine skiers, and 1 football player. And this is part of the generalized warm-up, and then later in the session we divide them into more sport-specific exercises. We all know that there are several return to play test batteries, and I will not be able to tell you which one is the best because we don't know. What we do know is that when we're returning athletes to sport, we usually do some kind of hop tests. We do muscle strength measurements, and we should do patient-reported outcomes as well. In our clinic, the return to sport criteria are quite similar to most others, I think. We have decided that they should have muscle strength measurements more than 90% of the opposite leg. I'll come a bit back to that later. Hop tests, the same, 90%, but we've also added with adequate strategy and quality. So we have to watch and look at the patients, athletes doing the test and see how their landings are. We're not using video analysis, but maybe we should to get a even better impression. And also, and for me, this is the most important part of the return to play decision. They have to perform a gradual increase in sport-specific training with adequate movement patterns. And then we have to collaborate with other people, coaches. Because the coaches, they can see things that I can't see. They know how that athlete is moving on the field and how they are behaving themselves. So movement patterns, collaborating with coaches, that's a good thing. And they should be able to do it without pain, effusion after training, and fear of re-injury. And also, we have this schedule that we do structured functional testing, not only for return to sport, but part of their rehabilitation progression. So we always do a clinical assessment, and we do muscle strength tests, and we do hop tests. Pre-operative, we find that very important, especially the muscle strength test. We want their quadriceps to be good before surgery. And as we also heard previously, the pre-operative extension is very important. Then after surgery, we do clinical assessment at 3 months, where we check that they have their extension, and if they don't have their extension and flexion, then we have to do something with it. We do muscle strength test at 6, 8, and 10 months, and we do hop tests at the same intervals. We also provide them with questionnaires, the IKDC and the COS questionnaires. And then again to this question, leg symmetry index of 90%, is that good enough for return to sport? I don't think so, at least not by itself. It's just a piece in the large return to play puzzle. Because the most difficult patient I can have is that if a football team refers a patient to me 9 months after surgery and they want me to do one assessment and tell them, is this guy ready to go back to sport? That's impossible, I think. Because the process of returning people to sport should take some time, and it should involve observations over time. And also with this 90% and the tests we're doing, we have this statement from the group looking at strength and performance criteria a few years ago, and they stated that the muscle function tests that are commonly used are not demanding enough nor sensitive enough to identify differences between injured and non-injured sides. And one example of that is that at the sports clinic where I've been working for 10 years, we have done 2,500 hop tests sessions with patients after injury. So not after surgery, but after injury. And how many giving way episodes have we had? 2, which is not good, but still, if we can do 2,498 tests without giving way episode, that tells us that these tests are maybe not checking the stability of the knee. Additionally, what does the literature tell us? We know that ACL reconstructed patients, they have residual quadriceps impairments, and we know that that affects their movement strategies. But we also see that it doesn't affect their return to sport rates. People go back with impaired quadriceps function. However, we think that that might affect the risk of re-injury, because today we've been talking about how many people come back to sport, but still we haven't touched on how many have to go out of sport again because they have a new ACL or other injury. So I want to share some data with you from the Delaware Oslo ACL cohort study. These data are still being prepared by Hege Grindem for publication. It's a prospective 2-year follow-up, and for this part it's 106 ACL reconstructed patients. And we have been looking at re-injuries. And people go back to play even though we tell them not to. So if a patient has passed the return to play quadriceps test, 90% of the uninjured side, then they have 5.9% of getting a re-injury. If they have not passed it, they have a 32.7% chance of a new injury. We also see that if they return to a level 1 pivoting sport, they have 4.9 times higher re-injury risk compared to if they go back to a level 2 or level 3 sport. And even more interesting, that if they return to competition before 9 months after surgery, 39.5% of them will have a new injury, while 19% of those returning after 9 months. And Hege, which is very clever, she's been calculating a lot, and she can tell me that the risk of re-injury decreases of 24% per month from month 6. So if you can have your patient wait 1 more month going back to sport, you will reduce the risk of re-injury with 24%. Muscle strength testing, there are lots of ways to do it. We tend to do it now as a power measure in the leg extension machine, like this. So it's a 1 repetition test with a muscle lab system. I'll show it again. So he kicks up as hard as he can, and you can see there's a small box here with a cord being pulled out, and then we measure how far does the thread being pulled out and what's the speed of it. So then we can measure the power at different loads. But there are other ways to test quadriceps strength, and I'm not going to go into different tests. I think the most important thing is that we actually do the testing, and there are several ways to do it. Also, these are the 4 mostly used hop tests: the single hop, the triple crossover hop, the triple hop, and the 6-meter timed hop. The triple hop for distance. You should try it for yourself. I usually say that, because we put patients through a lot of things that we haven't tried ourselves. And if you're going to jump 3 jumps and land on 1 leg, 1, 2, dunk. You should try that before you put your ACL patient through it, because it's quite some loading at the end. And I think it's very important that when we do these tests, we are really accurate measuring, and we have to make sure that we only say okay when they can stand still in the landing. If they're allowed an extra hop or some additional movement, then they actually couldn't control the landing. So these are the 4 tests: the single hop, triple crossover, triple hop, and 6-meter timed hop, usually being used in most publications. And we have the 90% cutoff for return to sport. Using other equipment, we're using again the muscle lab equipment. We are trying out now this test where we do counter movement jumps, and we measure how high they are jumping. So they get 3 attempts on each leg, and this is mostly a muscle strength test. So they get 3 jumps on each leg. And then I'll show you an example. This is a female handball player from the Norwegian elite. At her 6 months counter movement test, she did 14.5 centimeters on the injured leg, and she did 16.3 centimeters on her non-injured side. So that gives us 88%, almost 90, and more than 85. So should she return to sport? Well, she wasn't allowed to, and she came back for her 8 months test. Then she had improved, so 16.2, 16.8, and now her symmetry index is 97. But still with this, since she's part of our testing program, we knew that before her injury she had 18.2, and the national team average is 19.8. And then we were thinking, okay, this is 97%, but she's still 2 centimeters, or at least, yeah, she's 2 centimeters behind this, and this got her injured. So we have to improve them. They have to be better than what they were before their injury. And her landings were also quite stiff. So we continued rehab, got her back 2 months later for the 10-month test. Sorry, there. And then she improved very much. So I'm quite sure that her physical capacity and maybe also her risk of re-injury has been decreased quite a lot with those 2 months of extra training, even though she was at 97% at 8 months. And it's hard to do sport-specific tests, but we've also included this one now, which is a side hop test. We want to see how they're doing when they get tired. So it's a side hop test. You do as many hops as you can in 30 seconds. 30 seconds is a long time when you're doing intensive work, so you can see he's getting tired. And you don't need this system actually to do this test, you can just count. But you also should be careful not to count or give them instruction that if you put your foot on the tape, then it's not counting. So they have to go all the way over. This usually looks like this. This is the same patient, 6 months, 8 months, and 10 months. And you can see for this test also she was more than 100% actually at 6 months. We know that there are several agility tests. We usually try to use the t-test if we have the space. But it's hard to make something useful out of that test and other agility tests if you don't have a benchmark before they were injured. So I would say that my return to play advice, 2 points, would be that the return to play decision should be taken in a collaborative effort between the trainer, the physio, the surgeon, and the athlete, and it should be a decision taken over time. So the timing should be gradual and based on consecutive observations of knee function in sport-specific actions. And that actually just continuing Blanchard and Glasgow's model, going like this all the way through to return to sport. So my take-home messages would be that functional tests are important pieces of the return to play puzzle, but you can't use them independently. A graded progression through sport-specific training is imperative in the decision-making, and movement quality is as important as quantity. And quality is difficult to measure, so there we have to use our clinical eyes and our clinical reasoning skills. Thank you.